Hi, my name is Isabella Villarroel. I'm from Chandler, Arizona. I just graduated from Perry High School and will be attending the University of Arizona to major in medicine.
And I am Ethan Villarroel. I just graduated from Perry High School and will be attending the University of Arizona as a freshman, majoring in medicine.
Our lab mentor is Dr. Vandra, who is a professor in the departments of neurology and anesthesiology and the head of pharmacology at the University of Arizona. This summer, we got the opportunity to continue doing research in the Vandra lab.
The Villarroel lab primarily focuses on preclinical research regarding potential treatments for pain using both in vitro and in vivo methods. We investigate metabolic pathways to better understand how pain works while trying to find new compounds to help treat pain.
The main focus of the Vandra lab is to find non-addictive drugs that help relieve chronic pain. To answer this question, the Vandra lab has many different chronic and acute models of pain that focus on different aspects of the issue. In our project specifically, we are trying to answer the question, what is the effect of ALT-100 monoclonal antibody for treating breast cancer-induced bone pain?
The reason why we study this question is because metastatic bone cancer causes bone destruction and many novel chemotherapeutic agents that have adverse side effects. These compounds are also being explored as alternatives to current treatment options for chronic pain. This aim will investigate the effect of ALT-100, a monoclonal antibody, for the chronic pain associated with metastatic breast cancer to the bone in our cancer-induced bone pain model.
Our beginning questions include, what is ALT-100? What does it do? Out of the four groups, cancer with ALT-100, cancer with IgG, sham with IgG, and sham with ALT-100, which ones will help with tumor suppression? Will ALT-100 monoclonal antibody increase bone integrity? The experimental compounds were ALT-100 monoclonal antibody, IgG, and the cancer line EO771 cell line. The groups were sham control, sham monoclonal, cancer control, and sham monoclonal.
The graphic guarding also indicates that both have an effect on pain, but there is not a big difference between ALT-100 and IgG, with a similar amount of guarding of seconds on day 14. Comparing the graphs of flinching and guarding for the sham groups, the flinching seems to have a difference between the ALT-100 and the IgG, while in the guarding, the ALT-100 and IgG appear similar. The ALT-100 showed fewer flinches than the IgG 2 hours after injection. However, on day 14, both the ALT-100 and sham plus IgG did not show a difference. The graph of the guarding for the sham groups decreased around the same rate and did not have a big difference. But the ALT-100 did start to have less guarding from day 10 to day 14 compared to IgG. On day 14, the number of seconds of the ALT-100 almost completely leveled out back to baseline value.
In conclusion, this study demonstrates that ALT-100 effectively reduces the number of flinches compared to the IgG, but not in the case of guarding. This is an ongoing experiment that will increase the N number of groups. Our remaining questions include, will the H&E staining on the bone show a difference between tumor burden within the two cancer groups ALT-100 and IgG? Our second question is, would chronic dosing make a difference over acute dosing? Our third question is, how will different stages of cancer affect the responses of ALT-100 to tumor suppression? And our last question is, what would happen if ALT-100 is paired with another therapy versus a standalone therapy?